All right, you guys are all wound up. Okay. Okay, since you're all goofy, I picked a couple goofy ones. What do you call a person who doesn't toot in public? A private tutor. Okay. All right, what do you get when you cross a vampire and a teacher?
Night class.
What's that?
Night class.
A night class? That's pretty good. Blood tests. Okay. This one my little girl actually came up with. Like, she's 7. I think she wrote this when she was 6. Okay? And it's very, I think, appropriate for tonight. Because we'll probably see a lot of these out. What is Darth Vader's favorite dessert? Dark chocolate's pretty good guess. Nicely done, you're back. You have to listen carefully. You're going to see a lot of Darth Vaders out tonight, I'm guessing. Alright. Very important to record the jokes so that I can prove to my children that I'm funny. Because they tell me that I'm not. Dad, you're not funny, you're just lame. So there's a fine line between funny and lame, actually. Okay, so schedule-wise, we got Dr. Lewis coming for a guest lecture. We got cancer lecture today, and then we have endocrinology next week. And then on the 14th, we have, did I get like a shout out for endocrinology? Did somebody go, yes? That's awesome. Okay. Slightly nerdy, but really cool. And then the 14th is exam 2. Okay? Okay. Well, let's dive into this. Cancer. So, in a classroom this size, probably a vast majority has some sort of direct experience with cancer already. So it might be like a grandparent, it could be a parent, it may in fact be a sibling, or maybe it's a really close friend's parent. So there's going to be some direct experience with cancer. And obviously we're not going to be able to talk about all different types of cancers. And the ones that I'll pepper in throughout the lecture are probably things that have to do with my mom, because that's fresh in my mind. But fundamentally, what cancer has in common is what we're going to talk about in the lecture today. So we're going to talk about characteristics that happen at the level of the gene coding, things that happen within the cell, within the nucleus. We'll talk about how certain disease states are connected to cancer. There are certain chronic diseases that increase a patient's risk for developing cancer. And we start at the very beginning of the semester to kind of go backwards, flashback to Barrett esophagus. And when we first were spending time on that lecture, we talked about patients that wrestle with Barrett's esophagus are at increased risk of developing a certain type of cancer. Do you guys remember what that was? It's an adenocarcinoma, and it's in the esophagus, so it's an esophageal adenocarcinoma. So what's the connection there? Why? Why are patients that develop and struggle with chronic Barrett esophagus develop a risk factor that's orders of magnitude higher for adenocarcinomas in the esophagus? What's the connection?
Isn't it because when the cells change, the differentiation also changes, which means a lot of the transcription signals won't stop, so they won't reach that stop point. So it'll just be continuous growth causing a neoplasm.
Okay, so the answer is you're on the right track, and I'm just going to fill in a couple of extra details, but that's absolutely correct. So the answer that was given is in those patients, there's a transformation that takes place. Remember, there's a metaplastic transformation that takes place. And we move from a stratified squamous epithelium, and we move to a epithelium that resembles more of the stomach lining. And that happens at the level of the stem cell. And it's reversible if you get rid of the insult. But that insult is the hydrochloric acid that keeps coming up in a acid reflux or a regurgitation that takes place. And if it's left untreated, that creates an inflammatory response in the esophageal lining that's not equipped to deal with it. So the body adapts, it changes, it mutates. And that mutation isn't one and done. That mutation is you just started a cascade of events that will continue to progress, especially as long as that inflammatory signal is present. And so that's a theme that you're going to see throughout all cancer. Okay, there's going to be some stimulus, some trigger that's going to cause a mutation. And one of my really close friends, he's an oncologist. We were college roommates together. We took classes like this. You know, we were those two nerds in the front row that, you know, were always asking questions, you know, the ones that you just were like, oh, right? That was me and Justin. So Dr. Floyd, I've been talking a lot with, you know, walking through cancer with my mom. And it takes you down all sorts of different pathways. And the thing that's so frustrating is you're trying to predict what it's going to do, and cancer is unpredictable. Because the nature of the beast is it's mutated and it doesn't stop mutating. And so what a cancer is that you start treating, a lot of times it becomes something else, or it switches into a slightly different phenotype, and now it's non-responsive to the chemotherapy agents that you originally were prescribing. Okay? So I think the general understanding within the population is not so great. And so one of the benefits of this class is to try to provide some general understanding about various pathologic conditions. And cancer is one that we're always wrestling with. But we always get the question, why is it so difficult to treat? Like, you know, we figured out how to, like, you know, eradicate polio, and smallpox aren't around really much anymore. And there's all these really terrible diseases, but like cancer, why can't we find a cure for cancer? And the biggest fundamental reason for it is what was just answered there, is that transformation, which is exactly correct, happens and it doesn't stop. The cells continue to mutate. And I'm going to show you a slide later in the lecture, and I will point back to this little introduction. And we're going to see sort of a lineage, a microevolution lineage of how a cancer cell becomes more and more aggressive. Because you've heard terminology like, well, the cancer's seems like it's very treatable. The patient's responding really, really well because it must not be a very aggressive type of cancer. You know, what does that mean? Versus the opposite, which isn't as such great news. It's a very aggressive cancer and it didn't respond to the chemotherapy. What does that mean? So it works sometimes and it doesn't work other times. Why? And it's because of the mutations that take place. Okay, so we're going to talk about those things. And again, we have, you know, like an hour and 50 minutes, an hour and 55 minutes. So we're not going to cover all different types of cancers. We're not going to be able to look at all the different types of mutations. We're just going to scratch the surface and get you an exposure to it. Okay? So let's start with some terminology. What is cancer? Well, simply put, it's uncontrolled cell growth. And that uncontrolled cell growth is your cells. So cancer is not contagious. You can't catch it. They're not foreign cells. They're not something that infected you. They're your cells that are misbehaving. So they're in a state where there's uncontrolled growth. And as the growth, or the tumor is another word for it, forms, you get this dysplasia, or this dysplastic neoplasm. And dysplasia is a term that means a malformation. So it's something that's there that's not supposed to be there. And a malformation, new growth, is literally how that translates. Dysplasia to a neoplasm. And you can kind of appreciate in these cartoon pictures on the right, this is the muscularis mucosa of the gut down here. So this is in the GI tract. So this would be like colon cancer. And in this first slide, you can see one of these cells that's, colored a different color because it's trying to indicate that it's misbehaving. And then you can start to appreciate it's definitely misbehaving as it breaks outside of the normal boundaries and starts to invade the surrounding tissue. And this is a characteristic of cancer that is categorized as more aggressive, as where it starts to move outside of the margins or the borders of the normal tissue. And then over here you can say that this is very invasive because it's broken through into the submucosa through the muscularis layer. Now we have two big types of categories, and hopefully we'll put into some context terminology that will give you some tools to be able to pay attention and have, I think, intelligent conversations with even family members as they wrestle with issues with cancer. And as you move on in your studies, you might decide to move into cancer medicine. Who knows? Okay. The other thing before we get into benign versus malignant, how old do you think cancer is as a disease? Any guesses?
Since the dawn of time, just to never see what happens.
Okay. You're not easily tricked. Perfect. I mean, it's probably been around since humanity's been, walking on two legs. Has the prevalence increased? Well, we document things better now, so it's easier to count. So the numbers go up because we document more and the population increases. But it's probably been around for a long time, but we're just, in more recent present, able to understand what's going on. Okay? So now we have these categories that we put on cancer. Cancer doesn't care if you call it benign or malignant. Okay? It's going to behave the way it wants to behave. But what do these two terms mean? What do you guys, why don't you share with your neighbor, if you did the pre-quiz and you looked into the reading, you probably have some intelligent answers that you can already share with your neighbor. So go ahead and talk to your neighbor about benign versus malignant. Some ideas to share. Benign versus malignant. Okay, so benign is going to be really confined to a certain area, and malignant is going to be spreading to other areas. That's good. Anything else?
Sure. Benign won't necessarily cause major health issues, and it's easily removable via surgery.
Okay.
Malignant crossing over multiple boundaries, affecting the organ systems, and causing major problems for the immune system.
Okay, so benign is more surgically resectable. It stays put. It doesn't lead to as many health risks. Malignant, on the contrary, doesn't stick around where it originated, and it moves and invades other tissue beds. Okay? It becomes more complicated to do surgery on, and it may lead to other complications because if it goes from one tissue to another, now you have two tissues that have cancer. Do you have something else to add? You took it? Shame on you. Okay, so there's a great chart here that I want to share with you guys. And this kind of compares and contrasts benign versus malignant tumors. And so on the left is benign that has some traits just like your classmates were talking about. So it's slow growing. Another way of saying is you have low mitosis levels. You have very well-defined borders. It's non-invasive, meaning it's not going other places. The cells are well differentiated. What that means is they look like the tissue that they come from. So if we're in the uterine wall, they're going to look like an endometrial smooth muscle. Okay? If they're in the lung epithelium, they look like lung epithelium. Okay? If it's in a lymph node, it looks like lymphatic tissue. That's well differentiated. There's no metastases that are observable. Metastases, or METs, are secondary breakoffs that take place as they move to another location. Metastatic lesions. So we don't see any of those. We typically don't call it cancer. We say that it's a benign tumor, or it's precancerous. It's not dangerous. We're not too worried about it. Let's watch it. Let's bring you back in 3 to 6 months and let's take another picture and see if it's looking the same or if it's starting to change. What kind of change are they looking for? Well, it becomes less differentiated. It has not well-defined borders. It gets more irregular. These are the kinds of things that we're talking about. So for example, if you have like a lesion, a brown lesion on your skin, maybe a mole, okay, or a birthmark, and you feel like it's got more raised or it's growing in size. And it's very difficult when this is in pediatric cases because they're growing anyways, okay? But if it's in an adult, they're going to probably take a picture of it. They'll probably put a ruler in the photo, trace the borders. They can kind of get some image analysis of the shape. And they might say, let's bring you back in 3 to 6 months because if it starts looking bigger or more raised or more irregular, then we're worried about melanoma and let's just take it out. Okay? So if you look at these pictures here, you can see this is a benign leiomyoma, and this is cartoon histology, but this looks like smooth muscle. If we go over onto the other side and we contrast it with a malignant tumor, this is something we call cancer. And this is very rapidly growing, a high mitotic rate, undefined borders, it invades local tissues, it de-differentiates, it becomes poorly differentiated where it doesn't start looking like the native tissue that it came from. And you can kind of appreciate that in this cartoon drawing of histology. Up here, it's really in the upper left, it looks really nothing like muscle. There's a little bit of muscle remnant down in the lower right. But we see that this is metastasizing, and you can see from this picture, it's starting to move throughout that endometrial or that myometrial lining. And if it can move outside of that tissue and get into the bloodstream or into the lymphatic circulation, it can travel anywhere in the body. Okay, so for example, so mom had a lesion in the lung, in the right lung, and well, still does, and it had metastasized to the brain. And so the last time we were together, I showed you some brain scans of mom's right hemisphere. And that was a secondary metastatic site that came from the lung. And as crazy as this is, we get into Barrow Neurological Institute, and they do a scan of the brain, and they first had diagnosed it as glioblastoma. A glioblastoma is a very aggressive type of central nervous system lesion, tumor, that's a primary lesion. And it has a very aggressive pattern, and it's not easy to surgically resect. And so it was bad news to find out that's what they thought it was. But then we had pushed for scanning from other places in the body. The family did, not the doctors. And we got a scan of the whole body and found that she had a nodule in the lung. And so now the diagnosis went from a primary glioblastoma to a secondary metastatic lesion in the brain that came from the lung, which is easier to resect surgically. And so again, it just goes to show you that a little bit of information doesn't tell you the entire story. You actually have to get the whole story. Okay? So a malignant tumor, and there's different categories, stage 1, stage 2, stage 3, stage 4 types of cancers that you've heard of. And stage 4 means that it's very aggressive and it's moved to another tissue. Okay? So that's benign versus malignant. So the good kind of cancer, if you could use that terminology, and then the bad kind of cancer. All right? All right, so let's look at some more terminology as we move through the lecture. So neoplasia. So a neoplasia that we're going to see, this is an oral neoplasia. You know, you go to the dentist, and they're always like, you know, stick your tongue out, like, and then they grab it with like a 4x4, and they're like lifting it up and moving it to the side. and they're asking about your trip to Disneyland while they're doing this, right? And you're like, You're like, oh, really? It only took you an hour to get through Space Mountain? And, they can understand you while they're examining you. They're looking for things like this. They're looking for these little neoplasias or new growth that aren't supposed to be there. So we use this terminology called transformed, and we say that these cells become transformed because they no longer behave like their original condition. They're transformed into something else, and they're operating outside of these regulatory influences or cell growth mechanisms. And we'll talk a little bit about those throughout the lecture. So continuing with the theme of terminology, a lot of times these things are named off of the tissue that they come from. And we've got some examples here that we're going to walk through. So a carcinoma is usually transformed epithelial cells. So we said a esophageal adenocarcinoma is in the esophagus, epithelial cells that are in that location, and we call that a esophageal adenocarcinoma. So on the upper right, this picture of the nose, this patient's nose, is a basal cell carcinoma that's influencing that lower level of the epidermis. An adenocarcinoma usually is referring to glandular type of tissues. And so we say an esophageal adenocarcinoma because we now have goblet cells that are in that location and we didn't have them before. So that's why we don't just refer to it as esophageal carcinoma, which is epithelial, that's right. But we add the word adeno because of the glandular nature. So adenocarcinomas are found in prostate glands as well. Other glands or tissues throughout the body, like salivary glands, would be a location where you would see an adenocarcinoma. And of course, our bare esophagus patient because of the goblet cells. The sarcoma, the word sarcoma, this is transformed connective tissue. And then leukemia, we don't have pictures of those previous ones, otherwise I would point them out. Leukemia is cancer of the blood or the bone marrow, and that's this blood smear picture right here. And then lymphoma, this bottom one, this isn't a calf, this is actually a forearm. And that's a lymphoma, that's cancer in the lymphatic cells of the immune system. And so a lot of the lymphoid organs, like even lymph tissue, lymph nodes, lymphatic regions, even like spleen or splenic tissue, can be associated with the lymphoma. The big one right here, this H&E picture, this is prostate cancer. Okay, so this is an adenocarcinoma of the prostate where the normal prostatic cells are right here, kind of in the middle. And then over here, you can kind of appreciate how these cells are swollen and bigger, and there's more of them. And so there's another cluster over here that looks abnormal. There's another cluster up here that looks abnormal, and then the upper left looks abnormal. The only normal-looking ones are right down the center. You see sort of the streak of normal-looking prostatic glandular tissue down the center. You can even circle it on your slide if you have a printout. And then up here is abnormal, abnormal, abnormal. Okay? The last one that's listed here is referred to as kind of a funny term, a carcinoma in situ. So this is a terminology that's used for an early form of cancer that's usually defined by the absence of invasive tumor cells. And so it stays in location. And that's what in situ means, is in location. So it's a phase of the cancer before it crosses the basement membrane and gets metastatic. So it might be a carcinoma in situ, maybe something where we say it's benign, but we're worried about it becoming metastatic, and it's right before it becomes metastatic that you catch it. All right, let's look at another example. This is a benign glandular tumor, It's not a tumor. It's a glandular tumor. And this is a colon polyp, or a colonic polyp. So this is the epithelium of the colon down here. And at this top of this ridge, you've got this little polyp, or this structure, that these cells are growing abnormally out of control. It's supposed to just take this turn right here. It's not supposed to have this sort of little mushroom top on it. Okay? And so this is off of a biopsy that's taken. Probably colonoscopy first was introduced to the patient, and they saw that there were polyps. They could see them. And so they went in and they actually snipped a piece of tissue and sent it out for pathology, and they confirmed that they have these colonic polyps. What we're worried about is we're worried that the tissues will invade the basement membrane and they'll become colon cancer. So that's why, if your dad's in his 50s, that's when you start getting your routine colonoscopies. Or maybe grandpa talks about his annual colonoscopy and you're like, la 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 la, right? Because he's excited about it. He wants to tell you how his day was, right? It was rough. Okay, you can tell him about your path exam. I can show you worse pictures, Grandpa. Okay. But what we're worried about is these polyps aren't as big of a deal if you can treat them, if you can get rid of them. And so that's why with these regular colonoscopies, mostly in males, is the high risk factor, right? So colonoscopies in males are to try to catch these polyps before they actually break through that basement membrane and become problematic. So, how do these cells even become cancerous? If they're our own cells, why do they start misbehaving? Well, they go through a transformation. We'll talk a little bit more about the genetics that takes place later. And they start behaving autonomously, all on their own. They are their own boss. They decide when they're going to divide, and they usually just divide and replicate all the time. They lose what's called Anchorage Dependence. And that's what's shown over here is under normal conditions, you get these cells that are colored pink right now because there's only a few of them and there's a lot of space. And we grow these cells in the laboratory. When they start running out of space, they slow down their growth naturally. So they have what's called contact inhibition, or anchorage-dependent inhibition. So if they run out of room, they stop dividing. It makes sense. So if you're building an organ, right, and you grow a lung, once the lung is completely formed, you don't want more lung tissue forming. And so our cells are designed with this anchorage dependence or this contact inhibition, where they stop growing when they fill the space. So if you have a cut, right, on your skin, one that you can actually visibly see, well, it'll, over time, you can take pictures of it every day, and it'll slowly close, right? Once it closes, it stops, magically. Well, it's not magic, right? The genes stop sending the signal to replicate more fibroblasts because you've actually reached your critical point and you don't need them anymore. Otherwise, every time you got a cut, you'd have like 3 times the thick of a hand, right? And so we would know the people that were more clumsy than others because, their arm would be like 7 times thicker than their neighbor. If they cut themselves shaving all the time, which I just gave up on that, then they'd have like a triple chin because they just kept growing. So it doesn't work like that. But cancer cells don't turn off. So they lose this anchorage dependence, and we enter them into this terminology we call immortal. Okay? Also great for Halloween, right? So immortal, cells become immortalized. What that means is they continue to divide and go on somewhat indefinitely. Now, there's 2 terms I want to introduce, and I'll get to your question: anaplasia and pleomorphic. And students kind of get confused on these 2 terms, so let's define them very carefully. I'd like you to write these down. So anaplasia is the loss of organization and an increase in nucleus size. That's anaplasia. So anaplastic cells, they lose their structural organization, and the nucleus gets bigger. And so the relative volume in the cell, the nucleus, say to the cytoplasm, the nucleus takes up a larger component of the cytoplasm. Why do you think that is? And then we'll get to your question. Why do you think the nucleus enlarges?
Has the DNA been altered, and therefore they continually reproduce?
Well, so the DNA does get altered, and if you're going through mitosis, when you go mitotic cells, you usually see a slightly enlarged nucleus. And so in these anaplastic cells, these cancer cells, you're going to see some monster nuclei, some really big nuclei, where that's kind of what the pathologist looks for, is they look to see and they scour, they say, okay, I see like a normal cell with like a nucleus dot, normal cell nucleus dot. I see a cell right here that's got a really big nucleus. What's going on there? That looks abnormal. And we'll show you some examples, okay? Pleomorphic. Pleomorphic is a term that means variable shape and variable size. So what that would translate to is if a normal myocyte is that big, right, and it's round, you might start getting cells that look like this, right? So they're like 4 times the size and they're oval. That's pleomorphism. And so cancer cells, when they start growing out of control, they start getting irregular. They look weird, strange, not normal at all. And so from a pathological standpoint, it becomes quite easy to find them if you know what the normal tissue looks like. Make sense? Did you have an earlier question?
So when the body encounters a tumor, when your body encounters a tumor, there is an immune response, right?
Yes.
So if you cut the vasculature or like remove whatever nutrients the system is getting, is angiogenesis present again? Because when you have these recurrent tumors and they continue to grow, your body recognizes this as a foreign mass. How does that work?
So that's a great question. So the question is, how does the body see a tumor? And when it does, doesn't it harbor immune response at it? And couldn't it cut off the blood supply? And why does it keep growing? Is that right? So like all those 7 questions are answered right now. Okay. So it's a good question. Some of it we're going to elucidate throughout the lecture. Some of it we won't have the time to cover. But the short answer is, what your body does, the mechanisms that we're going to cover is when the body detects that there's a mutation at the level of the DNA, spoiler alert, I'm going to tell you this later, but it pauses DNA replication, it checks the integrity, makes repairs, and then allows for replication to continue after it's repaired the DNA damage. Now, and we call those tumor suppressor genes that do that. The problem is sometimes they become mutated. And if they become mutated, they're not checking, and then the mutation gets through. Okay? Then let's say the angiogenic one. Your body doesn't have natural abilities to create anti-angiogenic conditions.
What I was wondering is that if you remove the vasculature via surgical,
or with drugs. And so some of the targeted chemotherapy agents are anti-angiogenic drugs to do exactly what you described. But our body can't do that on its own under most conditions. It figured out in development when it could do that, because you don't, in the cornea is avascular. In cartilage in your knees and in your joints, they're avascular. And so we have the ability to keep blood vessels from growing in certain locations. But when cancer happens, for some reason, those mechanisms are so old that we're not able to self-repair. So it could be another X-Men episode of somebody that has angiogenic capabilities, and they're like Mr. Anti-Cancer, right? I don't know what that looks like, fighting bad guys, but that would be cool. Okay. So how do these cells become immortal? We use this word immortal, right? And it's not a vampire type of immortal, okay? But it is immortal in the sense that the cell has sort of an infinite cycle that it never stops producing. And so if we look at this graph here, this graph actually shows that the germ cell line, right, at the level of our gametes, has a really infinite number of cellular divisions that can take place, which makes sense, because this is how we replicate. This is survival of the species. This allows us to procreate, is at the level of the gametes, our germ cell line, with spermatogenesis and with oogenesis, we have the ability to make those cells. It has a definitive period of time that it can do that as long as the organism is healthy, but it doesn't fade out. They don't poop out slowly over time. They just turn off because you're no longer at reproductive age. Okay? So they have an unlimited cellular division, but it's all tied to endocrinology. Now, if we look at our stem cells also do pretty well. But over time, as we get older, they become less capable of dividing. If we look at a normal cell, there's a period of time where it actually enters growth arrest. Okay? And when these lines get so low, we aren't able to continue on as an organism. Well, so we have this combat. We have this telomere. The telomere is an extra piece of DNA that sits on the end of all of our DNA, and it acts like a little bumper. And so when replication takes place, right, first you have to unzip the DNA, right, and then you allow for annealing to take place, complementary annealing. Well, unzipping DNA is a pretty aggressive process. I mean, you're tearing it apart, essentially. And so when you do that, you create damage. And so on the end of the DNA, we have these telomeres, which are like an extra piece of DNA, and the length is directly proportional to how many cellular divisions that cell will allow for before it actually is targeted for apoptosis. So longer telomeres give it further cellular divisions. And you can see that the germ cell line maintains their telomere length for a much longer period of time. Right? Now, what ends up happening to a normal cell when it goes through an immortalization is the cancer itself triggers telomere length increase. And as telomere length increases, now you start moving in the opposite direction of this normal graph. Kind of fascinating. So that's the strategy that cancer is using in order to survive, is it's increasing telomeres. So it's a DNA sequence that sticks on the 3' end of DNA strands, and it's found in really all eukaryotic chromosomes. Okay, not in prokaryotes, but in eukaryotes. So every time the cell replicates, it shortens a little bit. But in cancer has the ability to elongate or lengthen the telomere. So years ago, I was just, on an airplane, and I was reading this, and the article is in about 2045, and it's just to show you where this came out of. This is 2011, February 21st. Okay, so you can go Google it and look it up. But that's where this little article comes from. And this guy, I just like the picture. I could have just put the text in here, but it looks like he's from Flagstaff, so I thought I'd just say that. So the box down here, you probably can't read, so I'm going to read it to you. This is a publication in Time magazine. Now, this is a coffee table magazine, so it's not a peer-reviewed publication. But what I was interested in was their reference to this gentleman's work, and they're talking about work that was done at Harvard Medical School and was published in Nature. So Time magazine is referencing Nature. Nature is a peer-reviewed publication, and so this is what they're saying. Every time a cell divides, its telomeres get shorter, and once the cell runs out of telomeres, it can't reproduce anymore and dies. But there's an enzyme called telomerase that reverses this process. It's one of the reasons cancer cells live so long. So I was like, wow, they actually got that right. That's pretty impressive. So why not treat, but this is the cool part, why not treat non-cancerous cells with telomerase? In November, this is November of 2011, researchers at Harvard Medical School announced in Nature magazine, a Nature publication, which is a top level, if you publish in Nature, you have arrived. You're like a rock star in the nerd world. They administered telomerase to a group of mice suffering from age-related degeneration. The damage went away, and the mice didn't just get better, they actually got younger. So you can pull the Nature publication from the Harvard Medical School group, and you can read the data for yourself. But now what we're trying to do is a whole new field, right? The fountain of youth, again, is being pursued by trying to leverage extending telomeres using the enzyme telomerase to see if we can actually improve or increase longevity. So we know that it works, and cancer uses it. Now the question is, can you do it in other types of situations? Okay, so as we transition to kind of our next little category, I want to just kind of wrap up with a couple of top-level topics. So this is a situation, you've told your patient, you're playing doctor, okay? Your patient has a lipoma. He says he's really worried because his sister was recently diagnosed with a liposarcoma, and it sounds like he has the same thing. So what do you tell your patient so he doesn't freak out? From a terminology standpoint. So there's something on this slide that should give you a clue about the terminology.
Lipoma is benign because the suffix oma generally means that compared to sarcoma.
Do you guys hear that? Can you hear that? Say that a little louder.
The suffix oma usually means it's benign, so lipoma isn't as significant as a liposarcoma, so he's kind of fine.
So he's kind of fine, right? So after med school, you'll refine that. Kind of fine. I'm not overly worried. Let's keep an eye on it. Come see me in, 3 months. But he's actually absolutely correct. So the suffix oma usually refers to a benign lesion. And sarcoma, carcinoma, or blastoma are usually more malignant types of cancers. Okay? All right, so let me give you some examples of those two words that I want to make sure you understand really well for the exam. Did you guys catch that? Okay. All right. So Anaplesia is a loss of organization and increase in nucleus size. So can you tell me what kind of tissue does this look like in the upper right? Just generally, what kind of tissue does it look like?
Muscle tissue.
It looks like muscle tissue. I would completely agree. Now, some would say it looks like fat or adipose tissue. But if it was adipose tissue, instead of having coloration in here, these would be white vacuoles. You guys remember that? Yeah. Okay. Those of you that took 201 with me, I hope you're shaking your head yes, like fat. So these would be white, not sort of this pinkish reddish color. So this is some type of muscle tissue, right? You with me? And that's exactly what that is. That's normal skeletal muscle in cross-section. And then what the heck is this? This looks like a train wreck. What is that? It's not muscle tissue, is what you're going to tell me. And you'd be right. Okay? You ready for this? This is a rhabdomyosarcoma. R-H-A-B-D-O, myo, M-Y-O, sarcoma, S-A-R-C-O-M-A. Rhabdomyosarcoma, myo meaning muscle, sarcoma meaning bad or not so bad? Bad. When you look at it, what does it look like? Bad or not so bad? Right? This is before, this is after. Not good. Okay? So what are some things that you notice about that lower right image?
Huge nuclei.
Huge nuclei. I mean, look at this monster one right here. Okay? Mac Daddy right there. But all of these other ones, I mean, this is the same magnification. The nuclei are supposed to be these little, cute, delicate little circles. Aww. Funny, like, cute. These look like, aggressive, like, predators. You guys with me? Okay. So big nuclei. What else? Random sizing or variable sizing. Some of them are big, like these two. Some of them are smaller, right? Even these ones that are smaller than the normal size cell. And then the other thing is, look at this one right here. It's a small cell with a really big nucleus. Do you see the ratio? This is what I meant by the volume of nuclear material to cytoplasm. So you have usually anaplasia and pleomorphism happening at the same time. But definitions are different definitions. So pleomorphic characteristics are the variable shape and size. And you see how this one's oblong? And these ones are more circular. So that's pleomorphic. Anaplasia is the increase in nucleus and the loss of organization. Okay, but you usually see them together. But I want you to be able to discriminate between one versus the other. Fair? Okay. In cancer world, not always, but many times, we have the ability to look for certain types of tumor markers. So what is a tumor marker? A tumor marker is something that we're going to measure, and it's going to give us an indication of if there's cancer and maybe what tissue it's affecting. Okay? So I'm going to only highlight two, but there are many different types. A lot of times they're done from a blood draw or a urine sample, or maybe they're done from a sample of pleural effusion or CSF. Okay? They're classically found on or in the plasma membrane, that's what PM is, not in the afternoon. Okay. On the plasma membrane, or they're found in the blood, spinal fluid, or in urine. And you take a sample and you run a radioimmunoassay, which is just a tool to look for a certain protein or antigen. And the two that I want to highlight, we're going to be equally fair to both sexes. We're going to talk about a boy example and a girl example. Okay? So let's talk about the male first. In PSA, prostate-specific antigen is what PSA is. Prostate-specific antigen is an antigen that circulates in the blood at some low levels. And it's normally detected in men post-adolescence at low levels. And as men age, the prostate does slightly enlarge. Okay, that's one of the great benefits of getting older, I guess, is the prostate in a man actually gets a little bit bigger. And then that can have some influence on urinary incontinence or the frequency of urination. And so the prostate-specific antigen levels in men, as we age, right, might look like something like this. Okay? So let's say this is the male PSA. Now, let's say that this is at the age of 50. This is age in years. And this is PSA level. Okay? Now, what happens if at the age of 50, a gentleman comes in, this is the normal PSA levels of a male, comes in with a PSA level that's right here. What do? Drop out of school, dad's got prostate cancer.
Biopsy.
Okay, biopsy, you're just going to pin cushion it right away. Okay? Ooh, man. You don't do any other less invasive tests first?
It's quick.
You would definitely get an answer if you biopsy. Okay? But now so do you know that this is, what if this gentleman's curve has just always been like this? Do you know that? Right away? No. If you biopsied, yes. If you waited 3 months or 6 months and you got another sample and it was up here, then you might say, okay, now I'm starting to get a little nervous, I think we actually need to biopsy. Or maybe you biopsy right away. Okay? But that's how you would use a PSA level to make decisions. Does that make sense? So prostate-specific antigen is normally there in men, and it's gonna have a slight increase as a man gets older. And so if you just have a one data point, you have no idea really what's going on. And that's why the medical field is telling men, go in for an annual checkup. This is a blood draw. That's all it takes. Okay? And I know we're such wimps, we don't even want a blood draw. But that's all it takes is a little bit of blood, and then you can get your own curve and determine if this is actually a problem. Okay, so now let's pick on the women. Okay, so HER2. HER2 stands for Human Epidermal Growth Factor Receptor 2. You're like, oh, I thought it was because it was a woman, HER2. No, it's just convenient to remember. That's why I picked it. So Human Epidermal Growth Factor Receptor 2. So breast tissue in women has these HER2 receptors. And these HER2 receptors are very responsive to estrogen. And in breast cancer, HER2 receptor levels rise significantly. And so if you do, there's not a great blood test for it. You actually have to do a breast biopsy. Okay? And so you have to do a breast biopsy, and then you stain for the HER2 receptor, and you look to see if it's at higher levels than what really should be there. Okay? And you may actually take a sample from control tissue or from the contralateral breast to make comparisons, or you run family history. You say, you know what, family history, there's breast cancer in mom or in grandma, and you're feeling on self-exam. We did imaging, we saw nodules, now we did a biopsy, and I see elevated HER2. We don't need to take any more tissue, now we know what we're dealing with. Okay? So these are surface markers that are usually found either on the cell, they're circulating in the blood, they're found in the urine, or they're found in the cerebrospinal fluid. And we can use them to track disease progression. We can use them as a screening tool or as diagnostics. But again, I just wanted to walk you through sort of a diagnostic example of how you got to be a little careful just because you get this information. You want to put it in context. It may not be, you may not know at the age of 50, is this a problem? You either biopsy or maybe you wait a little longer and you get another sample and then biopsy. But I just wanted to see how doctors are using our tumor marker techniques.
Is the risk of waiting that 3 months is pretty low? Is that why it's like a common standard?
There's no single answer to answer that question. So you could be, in all fairness, you could be totally right. If there was prostate cancer runs in the family, and they came in for a single data point, and the level was a standard deviation above the norm, the patient may say to the doctor, I have a lot of anxiety. I would like you to image it and then potentially take a biopsy and just tell me what's going on. So that's absolutely could happen. But in the larger population, they probably would be a little bit more conservative because there are risks associated with biopsy. And so it might be a little conservative to say, you know what, I just want to see you come back next month. And let's see what your levels are. Let's see if that was a blip. If you just run high, maybe. Or is it something that we need to be paying very, very close attention to?
So the levels can't drop again though?
Well, yeah, there's variability in the tests. These are immunoassays, so they're not perfect. Right? So again, like all great science, you don't want to make a decision on a data set of an N of 1. Right? And that's all we got is an N of 1. So, you're trying to balance. I've got a sample size of 1, but if that's why it's the practice of medicine, it's not the science of medicine. Right? Because the science of medicine, you'd be waiting around for sample sizes that were robust enough, and you don't have the luxury of doing that sometimes. In science, we have the luxury of making experimental designs, and we can build experiments to give us sample sizes that are meaningful. Okay, let's take a break, and then we're going to come back, and we're going to start talking about the genetics component of today's lecture.